Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture, we're going to go through infectious disease pharmacology. We split this into two videos. The first one's going to be antibiotics, and the second one will be everything else. So let's first begin with some antibacterial concepts. Let's go through some terminology. Bacteriostatic means that it's going to stop bacterial growth. Bactericidal means it's going to kill bacteria. When we talk about bacteria, we have gram-positive and gram-negative. Gram-positive examples are things like staph and strep. Gram-negative examples are things like E. coli, influenza, and more. There's something called direct observation therapy. You'll see this sometimes in mental health. We mentioned it in that video. We're also going to mention it over here in terms of public health. Direct observation therapy is where a patient takes their medication under observation by a healthcare professional to ensure compliance. We do this when we're treating communicable diseases. We also do this in mental health to make sure patients are compliant with their medications. Antimicrobial stewardship. This is related to the fact that we have an issue globally with antibiotic resistance. Antibiotic resistance is the fact that a greater and greater percentage of bacteria out there are becoming resistant. So antimicrobial stewardship is our approach to deal with that. And it's centered around appropriate use of antibiotics. So a few key concepts here. First one, and this doesn't apply to nurses, this applies to the providers and prescribers, is to match the drug to the bug, meaning that we're going to learn about tons of different antibiotics, but not every antibiotic kills every bacteria. In fact, almost all antibiotics are going to be targeted to a specific group or specific individual bacteria. So we want to make sure we're giving the correct drug to kill that bug, that pathogen. For example, if a drug is going to kill Pseudomonas, it's not also going to kill E. coli. If it kills E. coli, it may not also kill staph or strep. So we want to make sure that we're giving the correct drug to the correct medication. Next, we want to use narrow spectrum antibiotics as possible. We want to avoid broad spectrum if possible. Again, that one falls on the prescriber. However, a few things do fall on the RN. First is to make sure that patients are properly educated to take the medication exactly as prescribed. Very often, patients understand that it's not good to be taking antibiotics or any medication. So very often they make their own decision. I shouldn't say very often, but often enough, they're going to make their own decision and say, well, it's not good to take antibiotics. Today's day 3. I already feel better. I'm not going to take the rest of my antibiotic. That's wrong, and that actually contributes to antibiotic resistance. So we need patients to take the full dose. Also, it's up to nurses to make sure patients are educated on vaccines because obviously we want to prevent as many infections as possible rather than treating them afterwards. Also, work towards disease transmission by offering all patients with an infectious disease the opportunity to get a work note or school note to avoid going in sick and transmitting their disease to others. A few more rules about general antibiotics. Antibiotics increase the risk of developing C. difficile. That's a GI infection that causes severe diarrhea. Antibiotics can also disrupt the normal vaginal flora and cause a yeast infection in females. When we talk about bacteria and we talk about infectious disease, we need to understand that there are multiple types of pathogens that we're going to be discussing. In this video, we're only going to be discussing bacteria. In the follow-up videos, we're going to have viruses and fungi, protozoa, worms. We don't have prions, but that's another one. It's important to understand one critical concept. A drug that is used to kill bacteria will do nothing to fight a viral infection. A drug that kills a viral infection will do nothing against a protozoal infection, and so on and so forth. You need to understand that because this is the foundation of the fact that when patients come in with a viral infection, they have the common cold, and they want an antibiotic, you need to explain to them that it will do absolutely nothing. Because that patient has a viral infection and they're wanting an antibiotic, it will do nothing. Antibiotic is for bacteria. They have viral. It makes no difference whether they take the antibiotic or not, other than the fact that it will negatively contribute to antibiotic resistance. Anytime a patient has infectious disease, remember when we give them antibiotics or antivirals or any of those medications, we're always targeting the pathogen. We're going to try to kill the pathogen that's making them sick. But in the meantime, the symptoms that they have, cold and flu, whatever it is, cold and cough, things like that, those still need some medication to actually help them feel better in addition to help their immune system kill off the bacteria or the pathogen. So you should always be recommending to the patient to take over-the-counter medication for symptom relief. All antibiotics, unless said otherwise, should be taken with food to prevent GI upset. When a patient has been prescribed to get cultures drawn from them, this is always done prior to giving antibiotics because as soon as you give the antibiotics, you might kill off every pathogen in that sample of fluid that you're about to test, that you're about to culture. There's something called a culture and a sensitivity. So when we get a culture, culture could be from sputum, from stool, from blood, from anything. When we get a culture, we're checking to see what pathogen grows in there. When we do a culture and sensitivity, and I want to make sure you know what that test is, a culture and sensitivity is a second step to the culture test. The culture test tells us what pathogen is growing in there. A culture and sensitivity is a second step. And now this tells us what is this pathogen sensitive to, meaning what antibiotic will kill this pathogen. If I have the results from a culture and sensitivity, I know for a fact that this patient's bacterial infection in their whatever, in their skin is 100% staph, and it's 100% going to be killed off by, let's say, trimethoprim sulfamethoxazole. That's what a culture and sensitivity does. It tells me exactly what pathogen, which I get from a culture, plus the sensitivity says, and for sure, it will be killed off by this and this antibiotic. That's compared to empirical therapy. Empirical therapy is a very important concept to understand because it's how we treat most infections today. If you go into the doctor for a strep throat or an ear infection, very often they're going to give you an antibiotic. Not always. There's something called watchful waiting, where sometimes when we know it's something that in a healthy person is just going to go away on its own, it is very often the recommendation to not treat it and let it go away on its own, even if it is a bacterial infection. That's a little bit beyond our levels. Let's get back to it. If they give an antibiotic, they're not testing, they're not doing cultures, they're certainly not doing culture and sensitivity. So how do we give these millions of antibiotics all the time for things like strep throat without doing testing to know that it's a culture, without doing something like a culture and sensitivity? And the answer is empirical therapy. Empirical therapy says that is a concept of treating based on statistical data, meaning we know that the vast majority, I'm making up a number here, but probably about 99% of all ear infections will be killed off with augmentin. Okay, augmentin is amoxicillin with clavulanate. We know that almost all ear infections will be killed off with amoxicillin. So once the provider has diagnosed the patient with an ear infection, we already know the next step that their treatment is going to be augmentin. Okay, obviously, if they're allergic to augmentin, we have a second and third and fourth option, but that's the way it works. That's called empirical therapy, where we're treating them off of statistical data versus patient-specific culture or culture and sensitivity. Let's start to talk about the actual drugs, starting with penicillin. Penicillin is the oldest class of antibiotics. It was very famously discovered by accident. And the drugs in this class include amoxicillin, ampicillin, penicillin G, which is IV or IM only, and a few others as well. These work, along with the next few drugs that we're going to talk about, by disrupting cell wall synthesis of the bacteria. Humans don't have cell walls. We have semi-permeable membranes. So this doesn't affect us negatively, but it does kill off the bacteria who do have cell walls. And by disrupting that synthesis, we kill off that bacteria. Some of the things that we use this for are strep, otitis media, and syphilis, as well as much, much more. And this is part of a group of antibiotics called beta-lactam antibiotics. Beta-lactam is a chemical structure of the drug. And if it has that beta-lactam, that's called the beta-lactam antibiotics. I don't think you'd really be testing on that at the RN level, but you'll definitely hear it in practice, especially in infectious disease. So it's a good term to know. The side effects of penicillins is GI upset. And again, one of the ways to avoid that is to have the patient take it with food. It can also cause extended bleeding time. Penicillin is the most common allergy in all of pharmacology. However, few things to know. First of all, while we do 100% respect every single chart, if it says they're allergic, we assume they're allergic. Do keep in mind, you may see some providers playing around with that a little bit, because we do know that a lot of patients who are allergic, say they're allergic to penicillin, don't have a true allergy. They just had a poor reaction, like getting an upset stomach or a minor rash. Next, there's a very confusing concept in how to treat patients with cephalosporins that are allergic to penicillins. Cephalosporin is the next drug class we're about to talk about, and it's very similar to penicillin. It also has that same beta-lactam chemical element to it. So it does have a lot of similarities. So if a patient's allergic to penicillin, there is a concern that they're allergic to cephalosporin. Here's the bottom line. If a patient has true anaphylaxis, meaning that a life-threatening reaction to penicillin, then we consider them to be allergic to cephalosporins as well. If they did not, if they report a minor allergic reaction to penicillin, then we consider them only allergic to penicillin, and it's safe to give them cephalosporins. That's the general rule of thumb. I've seen stuff all over the place with this, but that seems to be the consensus from what I've seen. You will see some books that say if they're allergic to penicillin, they're 100% can't get any cephalosporins. You'll see others that say they're completely separate and it doesn't matter. But the gist of it is that if a patient had an anaphylactic reaction, we're not going to play around. We're going to say, let's just call them allergic to all of it. But if a patient had a more mild reaction, then we say, we'll still consider them allergic to penicillins, but cephalosporins are safe. Next, let's talk about beta-lactamase. So beta-lactam is part of the chemical structure of penicillins and a few others, and it's the chemical element that kills off the bacteria. Well, some bacteria have evolved to have a sort of shield to protect themselves, to protect the bacteria, to protect themselves against our drugs, against our penicillins. So they have developed an enzyme called beta-lactamase. So when we use a beta-lactam antibiotic like amoxicillin, it's going to go to fight that bacteria, but that bacteria has this shield, this beta-lactamase, that gets rid of my antibiotic. So what do we do for that? We have an antibiotic, they have a shield against it. Well, we came up with a way around it. We have something called a beta-lactamase inhibitor. It inhibits beta-lactamase, and beta-lactamase inhibits beta-lactam. So let's see if you can keep up. Beta-lactamase inhibitors such as tazobactam, sulbactam, and clavulanic acid. Clavulanic acid we mentioned earlier is part of Augmentin. These three drugs are called beta-lactamase inhibitor. They do one thing. They block the bacteria from blocking the antibiotic. They block the bacteria from blocking the antibiotic. So once again, we have our drug, our weapon is called penicillin. The bacteria have their shields, it's called beta-lactamase. We have beta-lactamase inhibitors that come in and wipe out their shields so that the original beta-lactam that we gave can go in and attack. That's the gist of it. If you didn't follow that, I'm sure there are other methods of videos that might do more graphic stuff to explain it. It's not that complicated. Hopefully you understood it. It's also not that much tested on, but I do like students to understand that. Next, and one last thing, beta-lactamase inhibitors do nothing on their own other than just take down the shield. They wouldn't actually hurt a bacteria in any other way. So they're always given with an actual antibiotic, such as amoxicillin. Next, penicillin is common for patients to develop a rash. That's not an allergy. Just let patients know that is a known side or adverse effect. Next, cephalosporins. We mentioned this already, but let's get into it. Some of the drugs, there's more than 20 different drugs in this class. I put a few of the popular ones: cefazolin, ceftriaxone, cefepime, and cephaloxime. These work the same as penicillins. They inhibit bacterial cell wall synthesis. Some of the examples of what we use this for is CAP, that's community-acquired pneumonia, meningitis, a few of the STDs or STIs, as well as pyelonephritis. Same side effect that it has, that it can cause GI upset, plus cephalosporins have a risk of causing gallstones and kidney stones. We talked already about the allergy. I'm not going to get into that again. This is also a beta-lactam antibiotic. Again, we talked about it. I'm not going to get into it again. Cephalosporins are categorized by generation, first through fifth. I should update this because as of mid-2025, we're actually into the sixth generation of cephalosporins. I actually think I'm a year behind. I think last year already we had this first sixth generation cephalosporin. So each generation is becoming more broad and more powerful with some exceptions, but we shifted from where the very first ones were mostly targeting gram-positive to now they're targeting either both gram-positive and gram-negative or gram-negative, but they're definitely extending their breadth of what they cover. When we say cover, we mean what they'll kill. Most of the cephalosporins are given IV-IM. There are some of them that are PO, and patients should avoid alcohol while taking cephalosporins. Next, we have the carbapenems. This is another one that works by blocking cell wall synthesis. This drug does not use beta-lactams. Even if the bacteria that we're fighting has those shields, the beta-lactamase, they would still be defenseless against this class of drugs, even though this is a beta-lactam antibiotic. What do we use this for? We use this for systemic infections. This is the IV medication. It's a very powerful antibiotic. This isn't for your everyday stuff. We use this a lot in the hospital for patients that are having severe infections. Next, we have vancomycin. The drug class here is glycopeptides, but I've seen quite a few textbooks that don't put a drug class for this. They just leave it as vancomycin. Again, this works by disrupting the bacterial cell wall. We use this for MRSA, C. diff, and a few other things. Glycopeptides like vancomycin have a very specific and very much tested on in nursing school adverse effect of nephrotoxicity and ototoxicity. So it's harmful to the kidneys and it's harmful to the eyes. So that's something that you should know for testing purposes, that you may need to assess their BUN and creatinine before giving it, or you may need to do a hearing test. I'm sorry, I said eyes, I meant ear. A hearing test before giving the medication. I don't think that's actually the way it's done in real life by any means, but for nursing test purposes, I've seen that as a question. There's something called the vancomycin infusion syndrome or red man syndrome, and this is where we give the drug too quickly or too high of a dose. where the patient has a reaction of getting really flushed, a rash, tachycardia, hypotension. If that happens, depending how early you catch it, you might be able to just slow down the infusion, or you might have to actually stop the infusion. Depends on how bad the infusion reaction is. That's not an allergy, that's a known reaction to it. And finally, these are considered teratogenic. We don't use them in pregnancy. The next drug we have is aztreonam. I've seen a few of the newer guidelines calling these monobactams as the drug class, but some just leave it as aztreonam. These, again, work by interrupting bacterial cell wall synthesis, and we've come to the end of the bacterial cell wall synthesis ones. And these are used for severe infections. These are generally given IV or IM. Again, these are not for your everyday infections. These are for severe infections, mostly used in the hospital setting. Next, we move on to tetracycline. Tetracycline is the first of a few that work by inhibiting protein synthesis. So this can be a new mechanism of action for the next few classes of drugs. They block protein synthesis of the bacteria. Some of the things we use tetracycline for, and the drugs in this class include tetracycline, doxycycline, and others, are chlamydia, cholera, community-acquired pneumonia, H. pylori, and a whole bunch of others. These do have a few specific things, and these are very commonly tested on because it's patient education stuff, which you know that we love testing on it. So please take some good notes. Discoloration of growing teeth, which is one reason why we don't give it to children. It can cause increased sensitivity to skin. So for patient education, make sure they're wearing clothing or avoiding long sleeve clothing or avoiding sunlight. GI effects. Now, however, we talked about GI effects and the solutions to take it with food. Not on this one. This one should be taken with an empty stomach. And this one should be taken with a full glass of water. And patients should avoid dairy foods while on this medication. And finally, this one is also not recommended in pregnancy. Next, we have our macrolides. Macrolides is probably familiar to some of you under the brand name Z-Pak. The drugs over here are azithromycin, erythromycin, clarithromycin. This is another one that works by blocking protein synthesis. And this medication works for some STDs, for whooping cough, and a few other things. This one, like a lot of antibiotics, again, has the GI upset. This one, go ahead, tell them to take it with food to prevent that. Some of the adverse effects are hepatotoxicity, ototoxicity, and angioedema. Angioedema is facial swelling. If a patient does develop these, we would stop the medication. Zithromycin is our go-to alternate for a patient who's allergic to amoxicillin. So if a patient comes in with strep throat or ear infection and they are allergic to amoxicillin, they're going to get azithromycin in almost all cases. And the next one we have is oxazolidinones, and this drug is linezolid. This one works by inhibiting protein synthesis, and that suppresses bacterial growth like the last few that we discussed. The examples of what we use this for include MRSA and VRE, and this is most commonly used for resistant infections. We don't use this for everyday stuff, mostly because we want this to stay a very specialized antibiotic, and if we keep putting it out there, there's going to develop a resistance to it, so we like to hold on to it and save it for when we actually need it. Next, we have aminoglycosides. This is a pretty big class. It has gentamicin, tobramycin, and a few others. These, again, disrupt bacteria protein synthesis, and these are used for severe gram-negative infections. That's what we use these for. These are not your everyday drugs. These are not going to be first-line drugs. These do have some side effects of tinnitus, so that's going to be, again, with the ears, and some dizziness and weakness. These drugs are mostly given via the IV route. And these do have a few black box warnings. They have a black box warning for neurotoxicity, ototoxicity, nephrotoxicity, and neuromuscular blockade. These medications are also not to be used in pregnancy, and these are pretty much never given as a first-line drug. These are always a backup option if other medications are not working. Same thing with the next one, fluoroquinolones. Fluoroquinolones is a great class of drugs, but because of the side effect we're about to talk about, this has stopped being used as a go-to drug for so many different things. So fluoroquinolones, the drugs over here are ciprofloxacin, moxifloxacin, levofloxacin. These are really great drugs. They kill a ton of different bacterial pathogens, but they have one big issue. They have a black box warning that they can cause tendinitis and tendon rupture. So certainly don't give this to a patient that has a history of those. But in general, we don't use it as a first-line drug because of this issue, even though it's a really good drug. We use this for lots of different things, including the plague, anthrax, UTI, hospital-acquired pneumonia. This is one of the drugs that the U.S. government stockpiles in case of disaster, that we can give it out to treat a mass issue with anthrax or something like that. That would be ciprofloxacin specifically. Just an interesting note. Again, it's a really great drug. The big problem is the tendinitis and tendon rupture. Next, we have sulfonamides. The drug over here is trimethoprim sulfamethoxazole, which is TMP-SMX, which is more commonly known as Bactrim or Bactrim DS, which the DS stands for double strength. Bactrim DS is a very common antibiotic. It's very broad. It covers a lot of different things, so we like to use it a lot. How does it work? It inhibits synthesis of folate. And folate, by the way, is the same folate that pregnant or women trying to become pregnant are supposed to take. So you're going to notice in a second that this is teratogenic. But it disrupts the synthesis of folate for the creation of DNA, RNA, and protein. What do we use this for? We can actually use this for a bunch of different things, for skin infections, for UTIs, for PCP pneumonia, for a lot of different things we use this. And in a lot of cases, this is our go-to drug. The side effects of this drug are rhabdomyolysis. If you're not familiar with that, the big thing there that we test on is going to be muscle pain, that if a patient is on a drug that has a risk of rhabdo and they develop a muscle pain, that's a huge red flag to stop the drug. Certainly, if they develop tea-colored urine, then that's a sign that they're already developing rhabdo and we should stop giving the drug. And again, this is teratogenic. And again, anytime you see teratogenic, I've mentioned this in other lectures, make sure you alert the patient or make sure you confirm the patient's not pregnant by whatever means is considered acceptable, usually a pregnancy test. Next, we have nitrofurantoin. This is our go-to drug for patients that have a UTI, a female that has a UTI. In men, it's debatable whether this is our go-to or whether we use something else. How does this work? It damages the bacteria DNA. I've never seen that being tested on. Once we get to these specialized medications, I think we sort of stick to, with our testing, the three big ones: the disrupting DNA, which is what the fluoroquinolones do, the disrupting protein synthesis, which is what a bunch of them do, and disrupting cell wall synthesis, which was most of the first ones that we covered. What do we use this for? We use this for only one thing. Nitrofurantoin is a drug designed just for your traditional cystitis. Cystitis, in medical terminology, is a UTI. This is very often the first-line drug for UTI, as I mentioned, but this is only for a UTI. If the UTI travels up the bladder, the urethra of the bladder, up to the kidneys, and now that's called pyelonephritis, this will not help. Just an FYI, there is something out there called cranberry juice that most of you have probably heard of that is thought to heal patients that have a UTI. It does not. The evidence shows it can work to prevent UTIs, but it absolutely does not treat an active UTI. Last two drugs I'm going to talk about are rifampin and INH, and these are TB medications. Tuberculosis, for those of you that don't know, is the #1 most prevalent bacterial infection in the world. Not very common in the United States, but it is very common in other parts of the world. Rifampin and INH are the two core medications that we use to treat active TB. Plus, we also use these two medications to prevent TB in patients who are actively exposed to it. So you may end up, hopefully not, but during your career being prescribed rifampin and INH, if you took care of a patient and then you get a call the next day or a few hours later saying, hey, by the way, that patient you took care of tested positive for TB and you were exposed and not wearing an N95 mask. So let's go through this medication. It's used for the treatment and prevention of TB. It is also used off-label for some other infections, very uncommon to use it for anything else. The side and adverse effects are hepatotoxicity, and that's a big one, so make sure you know it. The next one as well, INH, which goes hand in hand with rifampin, is also hepatotoxic. The big one that I've seen tons of test banks ask is that this medication can change the color of your bodily fluids, like your saliva, urine, tears, to a reddish orange. Please tell your patients about that. Otherwise, that will freak them out when it happens. Next, we have INH. This is also the partner one for rifampin and used for TB. It is again used for the prevention and treatment of TB, and it again has the same hepatotoxicity. Plus, it's also used for peripheral, or it can also cause peripheral neuropathy and neurotoxicity, but it has that black box warning for hepatotoxicity. Now, if a patient does have TB, then not only are they going to get treated with rifampin and INH, they're going to get two additional medications, which are pyrazidamide and ethambutol. I don't see that tested on very often in nursing world, but just so you know, rifampin and INH are the two common ones that you get for treatment or for exposure even before you're positive. But if you are actually positive with TB, then we treat you with not only rifampin and INH, but also pyrazidamide and ethambutol. Hopefully you learned a lot. That was a lot of information on our first infectious disease lecture. The next one will get into viruses, fungi, protozoa. Here are the references. Hopefully you will like our video, subscribe to our channel, and also have a great day.